Hello and welcome to the Encephalitis Podcast. My name is Prav Prathapan and I'm from Encephalitis International. Today we'll be talking about sleep and encephalitis. Sleep difficulties can be a symptom of encephalitis as well as a potentially long-term after effect. So to learn more, I'm grateful to be joined by Dr. David Lee. Dr. David Lee is a chartered psychologist and chartered scientist who has been researching sleep and the psychobehavioral treatment of insomnia for the last 20 years. He holds memberships with the World Sleep Society, the British Sleep Society, the Institute of Occupational Safety and Health, the British Association of Brain Injury Case Managers, the Vocational Rehabilitation Association, and the British Psychological Society, where he also holds an associate fellowship. Dr. Lee has held various academic posts, but now works full-time as clinical director for Sleep Unlimited, a company specializing in the delivery of training of psychobehavioral treatment strategies for insomnia. Dave has also re-released a second edition of the book Teaching the World to Sleep, which is also available on Amazon for purchase. Thank you so much for joining us, Dr. Lee. Welcome to the Encephalitis Podcast. How are you doing?
Thanks, Prav. That's a lovely introduction. Thanks, and nice to be able to speak to you today, and also I hope useful for your listeners as well.
Wonderful. Thanks so much. Yeah, it's a really important topic. So just to start off, in what ways can encephalitis affect sleep?
Well, I mean, everybody's sleep gets affected from time to time anyway. One in four of us will have a clinical level of a sleep disorder at some point in our lives, very similar to mental health conditions like depression as well. Um, so that the kind of situations that we see with people who've got sort of complex presentations, like someone who's living with the effects of having an experience with encephalitis, is that we'll see all of those things that can happen anyway to anybody at any time, with that overlay on top of the insult, if you like, to the brain. So you've got the physical impact, mostly due to inflammation, which obviously affects how the brain's working generally, but sleep is controlled in the brain. So that's the first thing, and can happen quite in many cases, um, most cases probably, after contracting encephalitis. But, and then the healing occurs, hopefully. Then some people are left with dysfunction afterwards and disability afterwards as a result of the infection, which could then impact. And then you've got other psychosocial things that are going on as well, about how people are recovering, the impact on their lives beyond that, and how distressed they might be, living with a changed lifestyle as a result of having an encephalitis experience. So where is that person on the journey? How long ago did they have encephalitis? What's their recovery been like? What kind of support do they have? Are they back to work? Are they worried about finances, anxiety? All those other psychosocial things can come along as well. So in terms of treatment for someone who's had encephalitis, we're looking at all of those things. So it's much the same as we would with anybody who's got a sleep problem. It's just you've got extra layers involved.
Right, yeah, I think that brings me nicely to my next question. I think the key word here is like an overlay. So how
Mm.
how do sleep disturbances in encephalitis differ from more common sleep difficulties?
So same but different. That person might have lifestyle factors that are going on that would affect any of us. Drinking too much coffee, having a really chaotic routine, spending a large proportion of their lives in front of a computer screen and not getting any natural daylight. These are things which can affect any and all of us, and do. And then, of course, you've got the insult to the brain and how that's recovering from. So we'd be looking at, well, what lifestyle factors are going on that we might be able to adjust, but also managing the infection itself. So working with clinicians who are maybe prescribing medications or other rehabilitation interventions, and making sure that we can optimize those for those people, because we're certainly fully aware, and not just for people with encephalitis, but all sorts of complex presentations from meningitis, acquired brain injuries from trauma, um, symptoms of neurodiversity, the menopause, epilepsy, I mean, pretty much all syndromes, conditions, all of them are impacted negatively by being tired. And if you get people sleeping better, they rehab more effectively. They get better quicker. They've got more energy to engage in rehabilitation. Their mood is better. They use services less often. They consume less medication. and that's across the board. So anything we can do to optimize that person's sleep as they're recovering from encephalitis is going to enhance every other aspect of their life, psychosocially, but also in terms of their rehab as well.
Wonderful. And just before we started talking in the green, we were in the green room, as it were, and we were talking about the importance of talking about children who can be affected. So my next question is, sleep difficulties in children can hugely affect families. So what advice or recommendations do you have for families in these situations?
Sure. So this is another good example of overlay, because with children, obviously that emotionally they're developing, and so adults may be able to sort of contain and control their emotions more effectively than children can, and that's obviously the same for anybody. So children who have experienced encephalitis or other significant life-changing incidents in their lives are inevitably going to need a lot of support. And this then really touches into that psychosocial third element overlay bit. We really need to be supporting that child with, well, the family, essentially, because they're the ones who will be usually providing that care 24/7, especially overnight. Yes, we want to work with teachers and at school, and they have a part to play, certainly in terms of, say, pacing, and not overloading the child with too much stuff in the day, so they're not then overtired at night. Um, but really supporting family carers, because they're the ones who are dealing with things in the nighttime. And sometimes we also work with care staff, so overnight nursing care, and in certain situations, certain children might have requirement for that kind of care provision. So again, it'll be working with family or nursing night staff so that we can optimize sleep in the nighttime period. But your sleep, my sleep, everyone's sleep is dictated by what's happening in the daytime. So very often as well, it's working with the schools. And like I say, pacing is a really big part of that, especially in the immediacy of the recovery phase. We've really got to be careful that we don't overload people, to give them the chance to rest, to enable that brain recovery to happen. And a really common symptom of anybody who's had any sort of brain injury, and we could liken encephalitis to a brain injury, it's inflammation, really. And you can get that from blunt force trauma or meningitis or encephalitis or hydrocephalus. Um, they might need more sleep in the daytime. We see napping behaviors quite commonly, and they're very important. That's part of the brain healing itself. So we don't want to interfere with that. So if you're put to, especially if you're taking a child to school and the school is then expecting them to be vigilant and alert and awake and paying attention all day, that can be absolutely exhausting. And that can really negatively impact the rehab process. So often it's working, going to school part-time, not full-time for a while, scheduling rest periods within the day, for sometimes for quite long periods after the infection has cleared as well, to make sure that we optimize that brain recovery period.
Yeah, so important. And my next question is quite different. One term we've begun to hear is sleep hygiene. Could you
Mm.
explain what this is?
Yeah, it's most health professionals and others who sort of Google search sleep come across sleep hygiene, and it's a list of things, and um, there's not an awful lot of good evidence that it's very effective, actually, and it's often a little bit blunt, and it's always, if you do these things, it's going to sort your sleep out, and that's not necessarily going to be the case. Um, Most people in the who are working in health, the only thing they've really come across is sleep hygiene, and it just sounds a little bit silly, doesn't it? Clean sleep. So we're trying to sort of get away from that a little bit, talk about good sleep practices, but which feed into what NICE guidelines say we should be doing to manage a sleep problem, and that's a set of interventions called CBT for insomnia. CBT, cognitive behavioral therapy. I'm sure many of your listeners have heard of CBT before. There's lots of different types of cognitive behavioral therapy, anxiety for depression, for eating disorders. And we've got a variant of it in the sleep world called CBTI, the I being for insomnia. And a lot of that is putting in good sleep practices. So very generally, speaking, for all of us, and for people who've had a brain injury and encephalitis, your sleep is controlled by your brainstem. It's a biological process. It's something that's evolved in humans for 20,000 years. If someone has had such a significant catastrophic injury to their brain from a very severe infection or very severe trauma, they tend not to survive. If that person has survived, that means that the core bits of that brainstem are intact. The blood is still being pumped around by a heart that's being controlled by that brainstem. Your breathing is still working. You're still digesting food, and your sleep is still there. So if that person survived and is alive, the core bits of the brainstem must be working. And they do sleep, and they have to, because if they weren't sleeping, they wouldn't be here. So CBTI essentially is doing two things. Just put in everything sleep likes, and on the other hand, identify the obstacles and remove them. So that the obstacles could be caffeine or drinking too much liquid or a lot of stuff that you might see under sleep hygiene. But the other thing, the things that sleep really likes is a really good routine, and a routine that works for you, and the right amount of sleep for that person. Children need more sleep. People who've had a brain injury need more sleep to recover. So getting the right amount of sleep is really important, but getting good quality sleep. So the things that sleep likes is exposure to natural daylight. That makes your brain make melatonin, and melatonin is very sleep promoting. So encouraging people out of doors is really health promoting for all sorts of other reasons as well. You get serotonin for good mood. You get vitamin D made in your skin, which helps boost your immune system. And you get melatonin, which really helps your sleep. So that's a simple thing to do. Go outdoors a bit more. Don't sit in front of these too much. Put in everything sleep likes, good routine that works and is the right amount of sleep for you. Go outdoors. And then it's identifying what's getting in the way. For a lot of people, that's stress, anxiety, low mood. And we see a lot of that in people who've had brain injuries generally, and also encephalitis more specifically. They're quite understandably upset and anxious and distressed about what's happened and what the future looks like. So we would work with neuropsychologists, treating psychologists, to try and manage anxiety and low mood alongside doing positive things. But if you read a sleep hygiene sheet, so well, don't drink too much coffee, and well, I don't drink coffee, so it's not that. So it's not very helpful sometimes. So what we need to do is assess people and be quite tailored in identifying. We spend quite a bit of time assessing that person, see what their sleep's actually like, where it's going wrong and why it's going wrong, and then we can tailor treatment to that individual. Encourage more time outside, schedule rest periods we talked about earlier on, avoiding anything stimulating really. So nicotine is a stimulant, and caffeine, alcohol really interferes with sleep. So it's other lifestyle factors which loosely fit with some sleep hygiene advice, but it's not all there. And it's a very blunt one thing doesn't fit everybody. So actually, if you want good results, you do CBT for insomnia, because it works for 70% of people who engage with it, because it's tailored to that individual. And that's the skill of the clinician, is to do that really good assessment to try and work out, well, what are the factors that are in play here for Marjorie? Let's give Marjorie what she needs and not what she doesn't need. And let's identify what Terry needs and give him what he needs and not what he doesn't need. And everybody's different. You're Terry and Marjorie, they're both had encephalitis, but they're still very different. And it's about tailoring that advice to the individual. And if you do that effectively, you get a good result. 7 out of 10 people will improve, to go from the clinical range into the healthy range with CBTI. And we see that across the board. Children, adults, people with dementia, carers, perimenopausal people with neurodiversity, people with brain injury. Not a lot of research in encephalitis, but you can liken it to a brain injury. And we see about a 70% hit rate with CBTI with everybody who we work with. So there's no reason to assume a lot of people who are listening to this who might be struggling with their sleep, by trying out those sort of simple bits of advice, might move and improve 7 out of 10 times. That's what we see happening. 3 out of 10 times no. Now, who are those 30%? They're not entirely, but a lot of them may have significant psychological issues going on where we need to team up with clinical psychology to work with the high levels of distress. And that could be pre-morbid. That needs working through. And the other, certainly in the brain injury community more widely, we've not got good data from the encephalitis community at the moment. There's not been the research that's been done, but we see, and we would assume that this should be the same for people living with encephalitis. We see an increased incidence of sleep disordered breathing. So the respiratory centers in the brain are very close to the sleep centers in the brain. And if we have had some sort of brain damage, we can sometimes see sleep apnea or sleep disordered breathing coming in. And that's certainly more prevalent in people who've had some sort of brain injury. And sleep apnea, we need to treat in a different way. We wouldn't do CBTI with those folk. They'd need to be looked at by respiratory physiologists. We have a few on our team who assess for sleep disordered breathing, and respiratory medicine in the NHS will do that as well. So that's something we need to be aware of when we're working with people who've had any sort of brain injury. There's an increased likelihood they might have sleep apnea. We need to identify that and treat that separately. But a lot of people won't and will see benefit from doing the CBTI techniques that I've just sort of briefly run through there. Yeah.
Brilliant. I think, yeah, one thing that really stands out to me is the importance of routine and scheduling. I think that cuts across so many different things, and the hit rate of 70% after CBTI is incredible. It just shows the importance
Absolutely.
of it. Yeah.
Yeah, it really is. And I think the reason why is because it's tapping into core neurobiological processes that have to be working in all of us for us to be alive. Brainstem stuff. And a lot of it's fairly straightforward. Stop drinking so much in the 2 hours before you go to bed, and then I don't wake up so much in the nighttime because that trigger isn't there. And there's so many people that do that. Not just people who are living with encephalitis, but then the other thing is more support and the psychosocial support. And we do a fair bit of work in people who've had stroke and dementia as well. And when you have cognitive impairment and people may struggle to actually read the clock, well, then putting in that routine is tricky. So that's where we need the scaffolding with carers, with family members,
Mm.
technology to alert people, pings on phones, it's bedtime in 20 minutes, get your pajamas on, that sort of thing. So that's where we might need to innovate a little bit more and work with other stakeholders like family members or carers to implement some of this stuff if the person's, say, struggling with routine and struggles to read clocks, that sort of thing. Yeah.
Yeah. And one of the questions I was going to ask, you have touched on this, is when is the best time to seek specialized sleep treatment and interventions?
Well, as soon as possible, because all of the other rehab processes that you're going to go through, be they internal body stuff healing up or psychosocial external environmental factors coming in, your rehabilitation is enhanced significantly by being well rested. It's going to make everything easier. You'll heal up more quickly inside yourself, but you'll also have more motivation and energy to get outdoors, to engage, to go to school and get your GCSEs or whatever it might be. Now, if that person's exhausted, everything is going to be difficult and the healing process will be extended. There will be more requirement to rely on medications for longer periods of time. There's more psychosocial stress that goes on for longer periods of time. So as early as you can to get that sleep optimized, that everything else will spin out from that in a more positive direction. So it's often quite frustrating. Most of my clinical works with people who've had significant brain injuries, and some of them have had infections like encephalitis, but a lot of them have had traumatic brain injuries. And we meet them 4, 5, 6 years down the line, and they've been in a difficult place for a very long period of time. And it's a lot easier to manage sleep problems if they're young rather than if they're 5 years old, because maladaptive behaviors can come in over time. I'm really tired. Well, I'll nap in the day. and I'll drink loads of coffee to keep me going, and then I can't sleep at night because I'm really caffeinated. And it's harder to correct that later on. So it's a much easier from where I'm sitting is to meet people earlier and get the sleep work done early, empower, resource that person early on. That then just enhances their rehab trajectory and the time that it takes them to recover. Yeah.
Yeah, I love that word empowerment. It's yeah,
It's
really,
really
really
it's
important.
fundamental to the CBTI process. I mentioned NICE guidelines earlier. In the UK, it's CBTI is number one because it's not toxic and it's effective for 70%. The drugs are effective for more like 25, 30%, and they're toxic. But more significant, I think, to that is that the drugs are disempowering to the client. Now, CBTI empowers that client to identify what it is that's going on, that's going wrong, do the right things, educate them, get them doing the right things. They then learn how to manage their sleep problem and they go away. It's give the person the fish. You have to keep giving them the fish every night, whereas CBTIs teach that person to fish, and empowerment is exactly the word. Yeah. So they can go away with a set of skills that work for them, that tailored to them, and they can then manage their own symptoms in the future and they go away and they're less likely to relapse and come back and bother me.
Um, and you mentioned the medications, as something that can be a treatment, but it is an overlay, as you mentioned. So how do these overlapping aspects, such as other medications or even seizures and things like that, affect how you approach the treatment of sleep?
Sure. Well, we know that seizure activity is more frequent and intense and prolonged when people are tired in epilepsy. So if we get people with epilepsy, for example, sleeping better, they have less frequent, less intense, less prolonged seizure activity. So there's a big link going on there. And I mean, any complex client almost certainly is taking certain medications for not just their primary symptoms, but for other things as well. So it's very important to liaise with the prescribers of these other medications to just work out, well, what is necessary? Are the dosages right? We meet a lot of people who haven't had medication reviews for years and actually, well, no, we want to find out, we should probably get these things reviewed more frequently so we're not consuming too much. And also, so often think chronomedicine is called. It's becoming something that we're really only just starting to learn about. But certain medications can be more or less effective at certain times of day, and that might depend on individuals. So you've probably heard of chronotypes before, with morning larks and night owls. It might
Right.
be that certain medications are more effective for the morning larks and at certain times of day and less later, and the other way around for the owls. And we don't necessarily know that very well at the moment. There's lots of work to be done with that. But as generally speaking, if we've got sedating type medications going in, and a lot of those are related to pain management, which we see quite a lot in complex client groups, you don't really want to be eating those in the morning because it's knocking you out for the rest of the day. So can we put sedating medications in later in the day and other medications that might be more stimulant in nature? Can we put them in earlier in the day? So we want to get drug regimes monitored and reviewed frequently. We want to minimize the amount that's going in. If we're doing the sleep work and that person's feeling better, well, maybe they might need less antidepressant medication. Maybe they may need less sleep medication. So as we put this CBTI stuff in, which is empowering and non-toxic, can we take the toxic, disempowering stuff out? So we'll work with those prescribers in tandem and say, right, as we put this stuff in, can you monitor Marjorie and reduce her dependency on that to a certain type of medication? But we'd be working multidisciplinarily there, lots of interaction with the prescriber just to make sure that we're giving the same messages to Marjorie. She doesn't get confused, getting conflicting messages. But that would keep her safe at the same time and make sure that she's getting the medication she needs, but not too much and not at the wrong time. And again, that's a bit of a dance and a bit of clinical skill involved in working that out quite often. Yeah.
Right. And just for our audience, we mentioned the NICE guidelines, and just for our international audience, it's a reference to the National Institute for Health and Care Excellence guidelines that are in the
That's
UK.
that's
And we have mentioned we are coming towards the end actually of the podcast, so thank you so much. We have touched on the psychosocial aspects of it, and my final question was going to be, what recommendations do you have for people for whom school or work has been impacted by sleep difficulties?
Yeah, so we sort of touched on this a little bit earlier on, and I mentioned that we'll often liaise with schools, and we're talking about children, but obviously workplaces as well. So it's about what we in the UK would term reasonable adjustments, and there'll be similar terminology across the world now, where we need to adapt conditions at work and or at school, for clients who have experienced some disabling condition, and they might be trying to return to school, return to work. So pacing is the big one, but it's absolutely communication. It's making sure that you've got SEN, special educational needs coordinators at schools in the UK, and again there'll be equivalents in other parts of the world, and employers, managers, occupational health professionals within workplaces, to make sure that they are aware of the client and the conditions that they're living with, and then making those reasonable adjustments. And it might be a graded return, it might be reduced hours, it might be scheduling rest periods. It's usually all of those things and more. Maybe it's adaptations to the office space for comfort reasons, to desks sort of level, having a space to get to that might be quieter and more relaxing, so that they can rest if they need to do that. It's very much about communication with special educational needs coordinators, occupational health physicians at work, and nursing and occupational therapists, managers, head teachers, class teachers, MDT, multidisciplinary team. Make sure that everybody's all round the table and understands what Marjorie needs, and let's get as much scaffolding in place around her. And it will be different for Terry. He's going to need something else. So we have to be quite bespoke and individualized in how we approach that. But communication is absolutely the key, really, and making sure everybody who is involved is aware and has a chance to contribute and participate in designing the care package that is fully biopsychosocial, that we're managing the health conditions, the drugs and medication, what's happening around that client whilst they're at work, at school, and at home, and supporting families in that as well.
Brilliant. And that leads me to my last question, which is, could you tell us a bit about Sleep Unlimited and the work you and your team are doing there?
Sure. So we do, broadly speaking, three things. We train a lot of health professionals. So we'll have a lot of occupational health nurses, doctors, neurologists, psychiatrists, GPs, occupational therapists. A lot of occupational therapists come on our training, where we train them to do CBT for insomnia. So they can go and work and do this assessment and treatment process with their clients. So we teach them up to NICE guidelines, standards to do that. A lot of other training that we'll do within organizations to occupational health physicians and health nurses. We go and do talks to the employees. So it's on the training side. On the clinical side, most of my work's with people, as I mentioned, have had moderate to catastrophic end brain injury. Mostly they've had trauma experiences, but there's a whole bunch as well who've had infection experiences as well, like meningitis, encephalitis. About 65% of those are adults, and about 35% of those are children. So working with schools and special educational needs coordinators is absolutely quite a lot of the work that we do on the clinical side. And I do a bit on the forensic side.
Amazing. Yeah. And that does bring us to the end of our podcast. And I was just wondering, just before we close off, is there anything that we haven't discussed that you'd like to mention?
I suppose the big one, and this is just for anybody really, just some of the key things that we see really commonly is people waking up in the nighttime to use the bathroom. just avoiding anything stimulating in the 2 hours before bed. Eating, drinking, alcohol, nicotine, all these things are stimulating. Everybody sleeps. You have to. You can't survive without it. And if you're alive, you are sleeping. It just might not be satisfying enough. So, what are the obstacles? And the big ones we see are eating and drinking too close to bedtime. So, we could resolve an awful lot of sleep problems if people just didn't eat in the 2 hours before bed, didn't drink, they'd empty their bladder, then they don't wake up at 3 o'clock in the morning needing the bathroom. And that's really common. So I'd just like to share that as a general tip for anybody with encephalitis or not. Don't do stuff which is going to interfere with your sleep too close to bedtime. Eat and drink, of course, you've got to do that, but you don't need to do that in the 2 hours before you go to bed. Hydrate and eat your food earlier in the day. You've digested your food, it then allows you to get into the deep sleep. And I think the other thing, which is of particular concern, and is much, much more of an issue today than it has ever been, is the flat screen device that interferes with your melatonin secretion rhythm. So don't look at the screens if you can in the 2 hours before bed. If you can't, can you do 1 hour? Because we know that blue light interferes with people's sleep. And being outdoors is really health promoting because that natural daylight promotes melatonin production. But if you're looking at these, Alan, artificial light at night is really bad for us. And we're starting to find out more. It's probably carcinogenic being under these bright LEDs at night. Dim your lights, calm that environment in the house at night, helps you wind down and go off to sleep. The blue screens are just exciting and they wake your brain up and make that sleep difficult to have. Natural daylight earlier in the day is really health promoting. And we think that that actually it could be really, really very positive for our health, sleep, mood, and vitamin D production in the skin, which boosts the immune system. So getting natural daylight earlier in the day, mornings, early afternoons, is really good for us. But Alan, artificial light at night is really bad for us. And we're only, again, just starting to clock how significant that light is on our lifestyles. Chronotherapy again. Morning, natural daylight, early afternoon, natural daylight, excellent for us. But Alan, really bad for us. And we're just working that out now. So I suppose those would be two things I'd like to just sort of finish up on, just as good advice for everybody. And we are looking at these phones a lot more than we ever have done, especially our kids, which is a big concern. There's a load of other psychosocial issues attached to that too, which we haven't probably got time to get into. But yeah, that would be something I'd like to put out there for your listeners, if that's all right, Prav.
A lot of excellent piece of advice there, practical advice there, Dr. Lee. Thank you so much for that. And thank you so much for sharing your valuable expertise with us. It's been just a great pleasure to have you. Thank you.
Thanks very much. And if anyone wants more information, shameless plug. Cheers. Thanks.
Love it.
No, great questions and lovely talking to you. I hope your listeners have found that useful.
Thanks so much, Dr. Lee. And I'd like to thank you, the audience, for listening and watching. If you've been affected by any of the issues raised, wherever you live in the world, please contact our support services. Encephalitis International is here to help in whatever way we can to achieve our aim of ending death and disability from encephalitis. For all our information, as well as details on how to donate, please see the podcast description or visit www.encephalitis.info/donate. Thank you again, and see you next time on the Encephalitis Podcast.